Good afternoon or good morning, depending on where you are. Thank you so much for joining us today. My name is Andrea Harless. I am Senior Director of Government Affairs at G2G Consulting, and I am so happy to kick us off this morning as we discuss a really important topic, which is community-based support for maternal health. I want to thank our co-sponsors, Pregnant with Possibilities Resource Center, Bloom Behavioral Health, and Women's Health Advocates for sponsoring today's briefing so we can talk about this topic. As many of you know, the US has the highest maternal and infant mortality rate of any high income nation, and about 80% of those deaths are preventable and avoidable. And with timely and appropriate medical care, we could be avoiding those deaths. Women often will have a baby and then go to a doctor's appointment 6 weeks postpartum, and they may never see a medical provider again if they don't seek them out themselves. The entire perinatal period is a time of incredible transition, and women often find themselves needing help, whether physically, emotionally, mentally, financially. There's a lot of resources that they may need, but they may not know how to find them. And this is where community-based supports come in because those resources are very likely right in their community. We have some incredible speakers today. If we want to pop over to the next slide, who are going to discuss what community-based programs look like, why they are important, why are so successful. We're going to talk a little bit about community birth workers, community health workers. We are, of course, going to be talking about maternal mental health. This is something we absolutely cannot leave out of the conversation. Um, Maternal mental health conditions are very common during the perinatal period, but oftentimes they are going untreated. We do not want to be leaving this out of the conversation. This is important for community supports as well. We're going to talk a little bit about some federal policy opportunities to support community-based programs for maternal health, and then we'll close out with questions and as well as talking about those policy opportunities. But before we get started, I wanted to share a quick video from Congresswoman Lauren Underwood of Illinois. Many of you are familiar with Congresswoman Underwood. She's a registered nurse, co-founder of the Black Maternal Health Caucus, and she's really emerged as one of Congress's leaders in maternal health. She's a leading voice in this field. She's a lead author of the Momnibus Act, which she will talk about during her remarks, and has helped to elevate maternal health as a national priority. So we'll go ahead and play her video.
Hi, everybody. I'm Lauren Underwood, and I have the honor of representing Illinois' 14th Congressional District. As a co-founder and co-chair of the Black Maternal Health Caucus, I am delighted to be joining you for this event, and I'm grateful for your commitment to saving moms' lives and ending our nation's maternal health crisis. The United States has the highest maternal mortality rate of any high-income country, with significant disparities in outcomes, particularly for Black women, and the crisis is only getting worse. The data are devastating, but for many of us, this crisis isn't just about numbers, it's personal. In January of 2017, I lost my friend, Dr. Shalon Irving, to pregnancy-related complications just 3 weeks after she gave birth to her first child, a beautiful daughter named Soleil. I have heard from so many people who have shared their own stories with me, losses and near misses, tragedies that could have been prevented. The causes are multifaceted, and we cannot end the crisis without a comprehensive response. And the Momnibus is the answer. I am so proud to work with Congresswoman Alma Adams and Senator Cory Booker in advancing the Momnibus. The Momnibus is a sweeping package of 14 evidence-based bills that address every driver of maternal mortality, morbidity, and disparities in America. It includes investments to end maternal health disparities, grow and diversify the perinatal health workforce, expand access to mental health and substance use care for moms, lower healthcare costs, fund technological solutions to improve care, close gaps in medical research, improve data collection, and provide direct federal funding for community-based organizations that are working on the front lines of this crisis every day. The Momnibus is designed to solve America's maternal health crisis. I'm so glad to say that my colleagues in Congress are recognizing that the maternal health crisis is a problem that we all must work together to solve. In fact, when we reintroduced the Momnibus for the 119th Congress, we did so with more than 200 original co-sponsors in the House. To get this across the finish line, we need your voices and your advocacy to solve this crisis and save moms' lives. I'm incredibly proud of the progress we've already made together in advancing the Momnibus. In 2021, we passed the first Momnibus bill into law, the Protecting Moms Who Served Act. This bipartisan legislation invests in world-class maternity care for our veterans. Since 2019, the Black Maternal Health Caucus has also advocated for more focused and robustly funded maternal health research. We met with then NIH Director Dr. Francis Collins and explained this need, and he got it. After that meeting, NIH pulled together separate funding streams into what's now called the Improve Initiative, implementing a maternal health and pregnancy outcomes vision for everyone. Since then, we have successfully increased the annual funding for Improve to 9 times the amount it was originally funded for. And we introduced bipartisan legislation to authorize that funding for another 6 years. But that's not all. For the 6th year in a row, the Black Maternal Health Caucus secured significant federal resources to address our maternal health crisis and save moms' lives. In total, the caucus has already secured hundreds of millions of dollars in new federal funding for Momnibus priorities. This funding has stood up maternal centers of excellence, directly supported community-based organizations providing maternal health services in high-need communities, funded midwifery education and training, and so much more. And while this funding is already flowing into communities and improving maternal health care across the country, we must continue our fight to protect this funding, keep the momentum going, and get the Momnibus signed into law. As the Trump administration and Republicans in Congress slash critical and life-saving public health programs that support mothers and families, we cannot back down. From constituents contacting their representatives about co-sponsoring the Momnibus, to organizations including the Momnibus in their advocacy campaigns, to private sector companies engaging in this mission to build bipartisan support, we all have an opportunity to do our part to save moms' lives and end this crisis. So, thank you for your commitment to this work and the opportunity to join you today. I am grateful for the light that this event is shining on maternal health in the United States, and I hope that it inspires everyone to take the action that we know is needed. I hope to see you soon, but until then, take good care of yourselves.
Thank you, Congresswoman, for sending us that video for today. I would now like to welcome Veranda Rodgers. Veranda is the founder, president, and CEO of Pregnant with Possibilities Resource Center and Bloom Behavioral Health at Pregnant with Possibilities. Veranda started Pregnant with Possibilities more than a decade ago. She will share her story with you when she saw a need for this programming in her community, and her organization is incredibly successful in helping hundreds of women each year through the different program that she has. But Veranda has taken a step into advocacy as well because she knows the importance of actively advocating for better and infant maternal health policies at the local, state, and federal levels. I am so happy to have Veranda share her story and her organization with you. What she does is truly remarkable, and she is also a remarkable organization leader. So, Veranda, take it
Thank
away.
you, Andrea. I greatly appreciate that introduction. I also want to take this time to welcome each and every one of you, as well as thank Congresswoman Lauren Underwood for her unwavering leadership and commitment to advancing maternal health across our nation. I am Veranda Rodgers. I serve as the founder, president, and CEO of Pregnant with Possibilities Resource Center and Bloom Behavioral Health. For the past decade, I have spent my life building community-based solutions to improve maternal and infant health. But my commitment to this work began long before the organization was founded. I was actually a teenage mother navigating systems that were designed to meet all of my needs. The United States has spent more money on healthcare than any other high income nation, yet we still continue to experience unacceptable high rates of maternal mortality and infant death. Nearly 80% of pregnancy related deaths are actually preventable. These challenges affect families across every race, income level, and community, but they do not affect everybody equally. Black women remain nearly 3 times more likely to die from pregnancy-related causes than white women, and Black infants are more than twice as likely to die before their first birthdays. Right here in Ohio, infant mortality has reached a 10-year low, yet Black infants still die at 2.5 times the rate of white infants. So healthcare alone is not enough. Today, I'd like to share why community-based maternal mental health is one of the nation's greatest opportunities to improve outcomes, reduce disparities, and build healthier generations for the futures to come. So here we have a slide which talks about community-based care, which is actually built on what we say partnerships. So it's obstetric providers, hospitals, community health workers, doulas, midwives, behavioral health professionals, peer support specialists, home visiting programs, and trusted community organizations working together to support families. Together, we can address medical care, we can address behavioral health, education, care coordination, home visiting, resource navigation, while looking at the social drivers of health. When clinical care and community care work together, families receive continuous support instead of a fragmented service. Maternal health is influenced as much by where a woman lives as it does by the care she receives. So, understanding that transportation, housing, food security, untreated mental health conditions, social isolation, and a distrust of healthcare systems all shape pregnancy outcomes. Community-based organizations are uniquely positioned to address these barriers that we see in the rates and the disparities that you see listed here when we have understanding that we should trust before a crisis occurs. So if the organizations are trusted, we're able to extend the reach of healthcare by families being connected before, during, and after pregnancy. Organizations across the country are providing models similar to what we see here. Research demonstrates that reduction in maternal morbidity, neonatal mortality, preterm birth, and improvements in postpartum engagement when community-based interventions are integrated into maternal health care have better outcomes. The evidence tells us that community-based care works. The question is whether we are willing to invest in bringing the model to scale. So let's talk about community health workers. And right here at Pregnant with Possibilities, we use community health workers as a part of our model because it's where we build trust, and trust is not lost. They connect families to healthcare, to behavioral health support, to transportation, to housing, nutrition, and the essential resources where families remain engaged throughout their pregnancy and postpartum. We do that by making sure that it's provided with dignity. Community health workers also should be recognized and substantially funded as essential members of a maternal health care team. And so that is what we're actually working to bring, and we'll talk about as we go through today's presentation. So a little bit about Pregnant with Possibilities and why I founded Pregnant with Possibilities. I always say I was born on purpose for a purpose and the purpose that I serve. My mom's own struggles with fertility, the doctors told her she would never have children. I always say I'm an indication that children can be born, they can thrive, and they can celebrate major milestones. I was also a teen mom, as I shared. As I started doing this work, I realized that we have to be a part of the solution. If not, then you'll be a part of the problem. So I intentionally built Pregnant with Possibilities as a trusted community-based maternal health organization, focusing on addressing the root causes of poor outcomes through education, community health workers, behavioral health, youth prevention, fatherhood engagement, emergency assistance, and advocacy. Our goal is to help families give birth to healthy babies and healthy futures. So a little bit about our work, and we're based in Ohio, in Cleveland, in the Cleveland area. Our flagship program is our mom program, which is called Making Opportunities Matter. It's a combined culturally responsive education program with community health worker support, monthly case management, care coordination, and on-demand prenatal and postnatal resources. Participants that engage in this program receive monthly one-on-one case management, personalized goal setting, care coordination, and access to resources, as well as we have a full pantry at our facility that is a point-based incentive model that encourages consistent engagement. Participants receive education on healthy pregnancy, labor and birth preparation, breastfeeding, lactation, infant safe sleep, newborn care, financial literacy, family planning, stress management, mental health, and a myriad of other topics that essentially set them up for long-term success. Our support actually doesn't end at graduation, though. We have our secondary program, which will be the next slide, which is our after party program. Graduates are able to remain committed to a continuum of care through ongoing educational workshops, peer support, family engagement activities, and continue access to community health workers and resources throughout the postpartum period. By maintaining these relationships beyond birth, we're helping families not only build confidence, they're improving health outcomes, and they're creating lasting support systems. In 2022, we realized that 50% of all of our referrals were for mental health services. And we needed to, one, make sure that we were closing the loop to ensure that families were supported. And so in 2024, our organization grew and we recognized that maternal health could not be separate from mental health care. And that is why we founded Bloom Behavioral Health to eliminate barriers to culturally responsive perinatal mental health services by providing trauma-informed, family-centered behavioral health services for the birthing person, their support partners, and their children. The program offers individualized care, family, group therapy, mental health assessments, case management, substance use treatment, and we have innovative programs such as our HOPE program, which HOPE stands for Healthy Outlooks on the Postpartum Experience, which is for postpartum parents. And we also have a program called Thrive, which is for community health workers to ensure that they're not utilizing their own triggers as barriers to best support families and re-traumatize them. So we have care for the entire family in this ecosystem, not just for the individual. Our philosophy is simple. When we invest in a mother's mental health, we strengthen the parent-child bonding, we improve birth outcomes, we support healthy child development, and we build stronger families and communities because mental health isn't separate from maternal health. They're one and the same. We are Joint Commission certified, and we are credentialed to accept all Medicaid managed care plans as well as some private insurance as well. So in closing, organizations like Pregnant with Possibilities, Bloom Behavioral Health, the Illinois Public Health Institute, and the Policy Center for Maternal Mental Health, MI, and countless organizations are demonstrating meaningful change. And so right now we're going to take a moment to pause and watch one of our clients' testimonial stories. Her name is Brittany Berry.
My name is Brittany Berry. I am a single mother of 5. I joined the Pregnant with Possibilities mom group with my youngest daughter, Eden, right here. I was just looking for a support group to help with postpartum and just a community group just to be with moms and their babies. I actually was in this program 8 years ago with my son. I called 211 and was looking for a program to help moms with diapers or wipes or anything like that, or just anyone with mental awareness. And Pregnant with Possibilities was one of the programs that they had came about of giving me information to. So when I became pregnant with my last one, Eden, right here, I said I got to join because that was a very good experience. So, and then again, I met a new group of moms, and then, you know, their moms is here at this program as well. Pregnant with Possibilities program, when you are pregnant, that one was really good because it's a 12-week program, I believe. So you just meeting every week with moms, and they just a mental awareness, activities for you to do to get you ready for birth. And then once you're done when you give birth, the Bloom program is just mental health with postpartum depression, because every mom goes through it and you don't know the signs of it, and they help you identify the signs. And then again, they're just a group to help you with any concern that you may have. So It's a very good group. I feel this type of support is essential because Black moms everywhere don't have the support that they need. They are alone, and that was mine. So by having this, it was real good to have this group. Any moms that are out there, please call Pregnant with Possibilities. It is a very good program while pregnant and Blossom. It is a very good program for you to join. The community here is very good. Any assistance that you need, they are here, one phone call away.
And so I want to thank Brittany, who is not here with us. She's here with us in spirit for just sharing her story and being vulnerable. Understanding right now, our responsibility is to ensure that policy, funding, and healthcare systems evolve to support what communities have proven works, and that's community-based care. Every mother deserves the opportunity to thrive. Every baby deserves a healthy start. And so I want to thank you for your time. And now I have the honor of introducing Dr. Crystal Tyler.
Thanks so much for the introduction, and thanks to my colleague for going before me and Brittany for that amazing testimonial. Again, Crystal Tyler, she, her pronouns. I'm the CEO of the Illinois Public Health Institute. I also serve on the boards of Orchid Capital Collective, the Black Women's Health Imperative, and the Society of Family Planning. So the strength, back one slide. Thanks. The strength of this country is really upheld by the strength of its families. And every family begins with a woman or birthing person whose health, dignity, and care were either protected by the systems or neglected by the systems. Maternal care is not just a women's issue, it's the first public health decision we make about every generation. And maternal health doesn't just begin when someone enters the hospital, and it does not end when they're discharged. It's shaped in homes, neighborhoods, and communities. And that means that an effective maternal health system must include both clinical and community care. Next slide, please. So one of our country's proudest promises is that we have options. You know, we love options here. Yet too often, viable maternal health options go underfunded or never make it into the conversation at all. And I'm proud to say Illinois has one of the most advanced healthcare systems in the nation. Yet still, our clinical and community-based maternal care occasionally sit at odds. And it's not because one works and one doesn't, but because investment flows more abundantly to one and more scarcely to another. And so this really is not a choice about should we go to community care or should there be clinical medicine? Families need both. The question is whether our policies and funding enable structures that support both to work together. So we've heard a little bit of a definition about clinical care and community care. I'll offer the definition from the Illinois Community-Based Birth Justice Strategic Plan, which was led by Black Midwifery Collective and Health and Medicine here in Illinois. And it defines community care as relationship-based, equity-centered, perinatal support for communities that have been unjustly served. And it identifies a range of workers and settings that within that care ecosystem. Next slide, please. So you all have probably heard this already. You'll likely hear it again. 1 in 3 U.S. counties is classified as a maternity care desert. And in Illinois, where I'm from, many of the counties have no maternal care providers at all. Community-based care is accessible, it's flexible, and it's effective at bridging gaps in clinical access and support. Trusted relationships with community-based providers are associated with healthier behaviors, lower stress for moms, stronger participation in perinatal appointments, and a number of other benefits. Doulas, which you'll hear more from Maya about, provide advocacy and support that's especially important for communities who've experienced discrimination within the healthcare setting. And community care does not compete with clinical care. It really extends its reach, helping families act on clinical guidance, and it addresses the conditions that determine whether care is accessible in the first place. So that role of community-based providers becomes even more important when healthcare coverage funding becomes less stable. Next slide, please. So we touched a little bit on healthcare coverage, but I'll say reducing healthcare coverage and the number of individuals who are able to be covered, it doesn't eliminate those healthcare needs. It just transfers the cost and the consequences of unmet needs to families, to healthcare providers, to hospitals, and to community organizations. Community-based providers tend to encounter those unmet needs first, and then they're tasked with addressing the increased demand for services without the necessary resources. Next slide, please. But the good news is that policymakers have already begun investing in community-based solutions. We've heard from our Illinois rep, Lauren Underwood, previously, and we know that those investments show us what is possible and what remains unfinished. These are just a few wins, but they're consequential wins, and there are others that you'll hear more about on this call. Community-based maternal care is no longer entirely invisible in public policy. We have direct federal funding for community-based organizations. We have Medicaid reimbursement for doulas and midwives and community health workers and birth centers. And we're investing in midwifery and maternal mental health and birth center expansion, which are all fantastic. But these remain individual investments. A Medicaid benefit without adequate reimbursement rates cannot sustain a workforce. Midwifery training without preceptors or places to practice cannot expand access. And a referral to community mental health means very little when the organization receiving that referral lacks the capacity to address the needs. And a plan to expand birth centers is not the same as funding them to open and remain open. So we've funded pieces of the solution, but we really need to think about funding and building the infrastructure that enables those pieces to connect, to scale, and to last. Next slide, please. So these systems level foundations are the infrastructure that allows community-based and clinical care to work together. Integration must be designed, financed, and accountable. And it must have supportive policy, sustainable financing, fair reimbursement, and workforce development. Next slide, please. So the Momnibus already provides a policy foundation through direct community organization funding, perinatal workforce development, maternal mental health support, and payment models for clinical and non-clinical maternity care. So this is where organizations like mine, the Illinois Public Health Institute, provide expertise as a resource. And I'm happy to offer introductions and continued conversations after the call. Next slide, please. Nearly 9 in 10 pregnancy-related deaths are at least somewhat preventable. Congress has the opportunity to strengthen these systems, name community-based care in legislation, fund organizations and workforce delivering it, build the infrastructure that connects community and clinical care. The call to action is clear. Please fund community-based care explicitly, adequately, and sustainably. I'd love to continue the conversation and move this work forward, and I will pass it over to my colleague, Joy.
Thank you, Dr. Tyler. Good morning or good afternoon, everyone. My name is Joy Burkhardt, and I am the CEO of the Policy Center for Maternal Mental Health. We are a 15-year-old nonprofit policy and practice think tank. We produce reports and insights for policymakers and provide resources to providers, community-based organizations, payers, philanthropy, and other nonprofit partners. We serve as an intermediary with a bird's eye view on the maternal health and mental health systems, and we chart paths forward. It's my pleasure to talk just a little bit more about what we're seeing in the field of maternal mental health and also mental health as it relates to community-based solutions and data and measurement. I wanted to start by reiterating what Veranda shared earlier, and that is some statistics about maternal mental health specifically. As we heard earlier, about 1 in 5 or 20% of the perinatal population, that's those who are pregnant and in the postpartum period, will suffer from a maternal mental health disorder. We'll talk about what those disorders are in just a moment. And also want to make sure that folks understand that Medicaid enrollees are more than 2 times likely to suffer from one of these disorders. Less than 20% of women are screened for maternal mental health disorders, according to HEDIS data. We'll talk about that more during the Q&A as well. And roughly 20% of maternal deaths are due to suicide. Also, overdose overdose is extremely important to be watching for as well with regard to maternal mental health. We have a fact sheet on our website that includes these statistics and more. The next slide, please. I wanted to share the range of disorders. First, to say that the baby blues are very common. They're not actually considered a disorder, but a symptom cluster feature of crying and sadness. Generally, the research points to the baby blues impacting 80% of women in the postpartum period. We also have heard stories about the baby blues potentially impacting women during pregnancy with changing hormones, though that is not researched currently. Of course, we all have heard about postpartum depression. We like to share and remind folks that depression can onset prior to pregnancy and not be treated or diagnosed. Prior to pregnancy, that's a third of all onset, another third in pregnancy, and that's important to detect and treat because of impact, of course, in the postpartum period if we don't rectify it and support women in pregnancy, but also the association to preterm birth and low birth weight deliveries, which are costly and, of course, cause lots of difficulty for parents, increased cost, their out-of-pocket cost as well. And then a third onset in the postpartum period. Equally as important to discuss is anxiety disorders in the green box here, general anxiety, as well as other anxiety disorders, which you can see here in the green box. We also want to point out that obsessive compulsive disorder is really important to pay attention to and impacts mothers in really difficult ways and can be mistaken for what we see on the far right side here, which is postpartum psychosis. Sometimes similar thoughts can enter a person's mind, and one set of thoughts is considered ego dystonic and the other dystonic. So thoughts that a mother is aware of are disturbing, and then in the other case of postpartum psychosis, the mother is not aware of her thoughts being inaccurate. And then bipolar disorder is not a maternal mental health disorder per se, but something that's really important to pay attention to during this time because of an increased risk for postpartum psychosis in particular. So increase in severity here on the bottom slide. So all of these disorders really important to pay attention to. It's not just the postpartum period, and it's not just depression. Next slide. We are working to rectify this situation in two ways. And one way is to integrate behavioral health into obstetric settings, and that includes screening, detection, and development of a treatment plan, but also believe in a no wrong door approach. We can move on to the next slide to explain this a little bit more. So, as I mentioned earlier, we believe that behavioral health integration into obstetrics clinics is really important. We call this clinicalizing maternal mental health. And we also believe it's important to communitize maternal mental health, as we've heard from both of several prior speakers before. Why do we feel like it's important to clinicalize this? Of course, as the number one complication of labor and delivery and birth, maternal mental health disorders should absolutely be talked about by a mother's clinician and obstetric care provider, such as her OBGYN or her midwife or her family practice provider, providing maternity care and labor and delivery. We also believe this is important in combating stigma, that this is not something that you've done wrong, but your body is creating these symptoms for a variety of reasons. We also, of course, believe that communitizing maternal mental health supports is really important. We mean both providing practical supports and also opportunities for social engagement through support groups, like what we heard Veranda talk about earlier through her Bloom program. These can include solutions like providing a workforce through peer support specialists, doulas, and others like community health workers, again, as we've heard from Veranda. These supports are generally provided through nonprofit organizations, as we've heard about previously, and can be reimbursed through Medicaid and even commercial insurance. Next slide, please. Let me tell you just a little bit more about these workforces. First, we know that this community-based workforce is community trusted. Often, women do not feel they can trust or that their providers, clinical providers, understand them. This isn't the case with midwives, but it can be the case with other medical doctors, as we've heard in the media and elsewhere. So building this community trusted workforce is really important to bridge those gaps. We are talking about community health workers. I wanted to share that 20 plus states reimburse for community health worker services right now. 2 years ago, CMS, the Centers for Medicaid and Medicare Services, provided reimbursement information in the physician fee schedule for community health workers. So we've seen a lot of advancement in states covering CHW services since that time. All of us, I think, in the maternal health space have followed the impact that doulas are making on improving maternal health outcomes. To date, 25 states are reimbursing doulas, and that's growing. And we mean Medicaid agencies are reimbursing doulas when I say states. And then peer support specialists actually been supported and endorsed by Centers for Medicare and Medicaid Services and SAMHSA, the Mental Health and Services Administration, for quite some time. And there are 48 states that currently reimburse through Medicaid for peer support services. Commercial insurers are often reimbursing community health worker services, sometimes reimbursing doula services, and unfortunately not reimbursing peer support specialist services often at this point. We have a report that we produced on what is the difference between these three workforces that we'll drop into chat in just a moment. As I mentioned previously, we also recognize, and we've heard earlier, that nonprofit community-based organizations are often the entity that provide services for this workforce and are becoming, as we've heard Veranda say, billing entities that will bill for these services on behalf of these community trusted workforce. We are tracking which services are provided with regard to maternal mental health by community-based organizations on our website, and we'll drop a link into chat of that webpage as well. And then the next slide, please. Lastly, I just wanted to share a little bit more about what's forthcoming and what we hope will be forthcoming with regard to measurement and data. With the unbundling of how we pay maternity care providers, such as midwives and OBGYNs, effective January 1st, 2027, there will be an opportunity now for the first time in over a decade to create a comprehensive maternity care measure set using claims data that will be submitted by those providers to determine whether the recommended care is being provided in prenatal care all the way through postpartum care. We'll also have an opportunity to align incentives to make sure that providers who are providing this important and evidence-based care are incentivized through pay for performance bonuses to individual obstetric providers. Also will provide an opportunity to look at community-based care and how obstetric providers are coordinating with community-based providers. And with that, I am pleased to turn it over to the next speaker. I'm turning it over to Maya with May.
Hello. It is such a joy to be with all of you this afternoon, and to Veranda and Dr. Tyler and Joy. I am awed to be in your presence, just deeply respectful of the work that you do, and it is work that I continue to learn from. So thank you. My name is Maya Hardigan. I'm the founder and CEO of an organization called May, which I've been leading for the past 6 years. Our work at May really focuses on supplemental support in community to our highest risk mothers. And we've really built May as a solution that is built around the needs of Medicaid beneficiaries very specifically, and built around evidence-based interventions that we know can impact their care, the quality of their care, and importantly, the outcomes of their care. So with the first slide, I'll share a little bit about what we do. Again, here, our work is really oriented around bridging maternal care gaps for those who need it most, right? And so we really lead with cultural alignment in the work that we do. We are embedded in communities, and we also combine that with technology that can really help us understand some of the specific risk factors for the moms in the communities we serve, and to again connect those to hyper-local community-based interventions. We have really leaned into work to help activate the community-based doula workforce for Medicaid participation, in part because of what my colleagues have shared today, right? Their presence with mothers is clinically impactful. They serve as peer supports. They serve as trusted advocates. They really serve as conduits to help us understand deeply the specific needs of the population that they care for. And so over the course of May's handful of years in existence, we have supported over 8,500 pregnancies. We work across 11 states. As Veranda and others shared, again, these interventions are clinically impactful. And so this is not a surprise that we have also been able to drive meaningful reductions in C-section rates, meaningful reductions in preterm birth rates. Again, we know what works in the maternal health space, right? And so our opportunity and our challenge is to really have the collective will to get these interventions to more of the mothers that need them. Our premise and hypothesis at May, as my peers have shared today, very aligned, is that we must align and strengthen the connection between community-based maternal support and the primary care infrastructure that we're surrounding these mothers with, right? In doing so, we know that we can drive quality performance, right? Things like timeliness of prenatal care, timeliness of postpartum care, mental health screenings, all of the sorts of things that we know inform higher quality outcomes. And we can actually also save money, right? Because we're helping these moms have higher quality births with stronger outcomes. We're avoiding those postpartum rehospitalizations. But on a human level, we are really helping mothers to mitigate, obviously, deaths, near death experiences, the sorts of things that really break down families, break down lives, break down communities. And so it is really critically important that we are working together to address these disparities in a meaningful way. We go to the next slide, please. All right. So part of what I wanted to share today with this audience, I think, is just the extent to which the individuals we support have social needs that are often otherwise going unaddressed. And so across our population, and I shared that we work disproportionately in Medicaid managed care. Across our population, we have approximately 60% of our moms who are struggling with SDOH, right, social driver health, that are really impeding their access to care, meaning that even if we were to have these mothers connected with the best doctors and those who weren't engaging with bias in care, there are a huge amount of moms who are not getting there, and they're not getting there because of other complexities in their lives and needs for benefits coordination and support outside of the clinical setting, right? And so I expected this and I knew this when I founded May, but I don't think I fully appreciated the extent, right? To say that over 50%, over 60% of our mothers were not able to get to their core obstetrics care because of factors like these, right? And some of the things that we're very often seeing across the population we support are things like unreliable transportation to get to and from the doctor, lack of access to healthy food, and a need for support and coordination around benefits, or even just an ability to access baby formula, housing instability, alongside that, not having a consistent telephone number to be able to follow up with and stay on track with those core obstetrics visits, general financial insecurity and lack of consistent employment, right, which really fuels that financial insecurity, even internet access, transportation access, all of these things. Very meaningfully here, a lack of social support, right? So not having anyone in their close circle that they can go to for mental health support, for, just shared community. And we also see really a breadth of need around general maternity benefits, right? In some cases, moms saying, I know that I have high blood pressure, right? I want to be able to track and monitor that at home, but I'm in need of a blood pressure cuff and things like this. And so I myself really underestimated the extent of need around some of these social factors that were really getting in the way of moms being able to engage around their core obstetrics care. I will also note here, because I think it's very meaningful, that a huge percentage of our population, in particular our BIPOC population, those who are people of color, very pervasively report bias in their care and a lack of trust, right? And when we think about this, it mitigates, I would say, one's ability to engage with their core obstetrics team in the way that we really need them to uncover some of these needs, some of these complexity in care, right? And so a big part of our work is thinking about how can we use our community doula workforces to help individuals with care reintegration and to get back through those doors, right? And so for us, generally speaking, it's been very obvious, very critical over the last 6 years or so that we've been working with Medicaid beneficiaries, that in order to drive higher obstetrics care engagement, in order to improve outcomes, we had to be thinking of these social drivers of health, and we had to be thinking about how we could better work to support them in community before mom even gets through those doctor's doors. Next slide, please. All right, and so here, I want to take the conversation back a bit to community birth workers and specifically community doulas. And again, I think I've just been so pleasantly surprised, really awestruck by the role that our community doula partners play. And at this point, we work with a community doula network of about 400 and growing every month. The expansiveness of their role in an individual's perinatal journey, I think is just something I could not have imagined when I was stepping into this work a handful of years ago. They they impact this experience in a few critical ways, right? One being their capacity for additional educational touch points, importantly in mom's community and in mom's home, right? So to the extent that we may see lower levels of core perinatal engagement, in large part based on some of the factors that I shared on the previous slide, these are opportunities for us to be in the home, to go to mom at the time of day works for her, in the place that works for her, to teach about birth planning, really to teach about self-advocacy in pregnancy, general pregnancy education that is so critical and also so correlated with those birth outcomes that we're trying to drive on behalf of mom. Generally speaking, in May's community of users, we have moms averaging about 3 prenatal visits, and that's either before labor and delivery, some fall in the postpartum stage. And we're also seeing our moms leverage their doula partners for labor and delivery support. So they are in the room with them on the day of, helping them breathe, helping them stay confident, really helping with you know, helping them to understand all of the interventions that may be occurring over the course of that labor and delivery, and that's been really critically important. Our doula partners, so importantly though, are also helping us with social needs screening, right? And so to some of the conversation we've had today, I loved what Joy said about any door, right? We will receive this information and inquiry of support from whatever direction or whatever means mom is able to alert us to it. It's been really important for us to actually have our community-based doula partners in the home, right? Having these deep, intimate conversations. But not only that, seeing a mom's space, right? Looking in the refrigerator and saying, mom has not indicated to us that she's food insecure, but there may be a problem here. Doing some of the more formal screenings, Edinburgh perinatal mood disorder screening, helping us to understand social drivers of health needs throughout the pregnancy, and sometimes very early on in the pregnancy, where our being able to engage around those factors earlier does make a big difference in outcomes. Importantly here as well, when we are building our community doula networks, we do that hyper locally, right? And so a best case scenario is if we're able to pair mom with a doula who lives in her own community. And what we've found in our work is that those local doulas who work on the ground are sometimes very, very, very familiar with local community resources and benefits, often that will even fall outside of the plan covered benefits that may be marketed to mom, right? And so they've been really critical brokers in terms of saying, mom needs formula, mom needs a diaper bank, mom needs this or that, and this is where mom can go in this community for that specific, and really helping us with those closed loop referrals, not only to drive the awareness to make sure that mom gets the thing that she needs and gets it in a timely factor. And lastly, here, I touched on this a moment ago, this very pervasive issue around medical distrust. And I think it's very important to say that this is not something to take lightly. Very often, individuals feel this way because of a poor experience they had, because of a poor experience a loved one has had. And these feelings are often rooted in fear, right? And rooted in trauma and rooted in something that's very real. And we need to respect those feelings. One of the things that I think has been critical in terms of a doula's role and what we've observed is the meaningful work they can do towards care reintegration. And sometimes that means doula even being by mom's side when she goes to the doctor, right? To say, I'm going to be there. I'm going to be an advocate. I'm going to make sure, we are asking the right questions. We're going to make sure that we leave fully understanding the risk profile the doctor shared, the next steps in care that the doctor shared, and we are going to show up together, right? And make sure that we can do that without fear, and also make sure that we can work together to confirm that you have the right team, right, moving forward. And so I think that's been a really, really critical role. And doulas being by mom's side to really bridge health literacy, I think has also been very meaningful. So we know this workforce does extraordinary work. And if we go to the next slide, I would love to speak to how we could better support them. One thing that is critically clear, particularly when we think about Medicaid managed care and the very new and emergent coverage of doula benefits. And I know when I was founding May years back, 4 states had Medicaid coverage of doula benefits. Now we have about 25, but it's actually over 30 if we think about those who have introduced near-term legislation, and hopefully we'll have it approved and moving forward within this calendar year, right? And so we're seeing a bolus of states now, the majority of states who are building the regulatory framework and pathways for this workforce. But we can also see in many instances that the workforce is too fragile. And in some cases, the workforce is too fragile because of how those policies have been defined and because of some of the administrative hurdles of engaging, right? And so it's already been mentioned today, payment rates, right? If we build a regulation, but we don't factor in a livable cost of wage for these individuals, and one that is really rooted in a sound ROI evaluation of the cost savings they drive, right, then we can really fall short and have a policy in place, but the workforce not follow because they cannot make a living wage or they cannot do this work full time, and therefore the capacity they can take is going to be very low, and we're not meeting the goal when we think about scale of this opportunity within Medicaid. So we really need to think about reimbursement in a competitive way and with a lens towards driving a sustained, healthy workforce because they can do this as a career and they can earn what they need to do that. Eligibility is another piece, right? Very often the state Medicaid agencies have very complex credentialing pathways, very limited or restrictive list of approved training entities whose doula graduates can be eligible for Medicaid reimbursement. And sometimes even incidental fees, right? Things like background checks, fingerprinting that applicants, and sometimes highly experienced applicants, don't have the personal funds to be able to get past, right? And so we would encourage here a rolling approval of training entities, particularly those who have a robust curriculum and really meet the objectives of the state, but also thinking about ways to reduce application barriers and even potentially waiving some of those prohibitive costs that are getting in the way of individuals being able to fully apply and do so in a timely fashion. Lastly, here on this slide, something that we see very often is a lack of comfort or familiarity from the perspective of doula and provider collaboration, right? And so we've had many instances of doulas saying, I'm comfortable working in this subset of hospitals, but this hospital really doesn't like doulas, and therefore I'm not going to be able to support moms who are birthing there, right? And what we've found is that when we're able to drive familiarity, learning, collaborative pilots so that the doulas can really get to know the core care team, but importantly, that core care team can really get to know the doulas who are coming into their facility and their mission and their intent, and understanding that those objectives are shared. We've really seen beautiful relationships around doula provider collaboration emerge, right? And so anything that we can be doing to support pilots, support opportunities for cross training, even just support opportunities for community between community-based doula and the providers who are, handling a lot of births in a region, that can be very meaningful towards supporting a longer term relationship. That is all I want to share. Again, here I think that we have the knowledge, we have the evidence, and the thing that we need now is the will to make it happen on a much larger scale and to get it to more people. And so I'm greatly appreciative of the opportunity to share today and be with all of you. And with that, Andrea, I think I have a few minutes for Q&A, so I'll hand back to you.
Yeah, thank you so much to everyone. Unfortunately, we only have about 3 minutes left. So, what I want to do, because we don't have a ton of questions, we've had great conversation in the chat here. But one of the questions that came up is how do we collaborate more effectively to improve maternal outcomes? So, each of our panelists, if let's do 60 seconds, what would you get? One, maybe two things, how we can collaborate more effectively to improve maternal outcomes. Whoever wants to start.
I guess I'll kick it off. So I would say for collaboration, I think it takes the whole ecosystem working together. I know here in Ohio, I actually meet on a quarterly basis with our healthcare providers, the gynecology and obstetrics team in healthcare. It also takes advocacy, so working and meeting with your local legislators, understanding the resources that exist within your community, and convening collectively together so that you're not just rich in resources, but you thoroughly understand all of the resources that's available in your respective states.
I fully agree with that. And then I'll add two pieces. One is, or I'll add an example and then an additional piece. So from a collaboration perspective, we have, I think they're quarterly calls with everyone who's in any way, shape, or form associated with lactation or breastfeeding or chest feeding. So it includes all of our state agencies who have space in that work in that space. It includes us. It includes providers who offer lactation services, and it's just an opportunity to share information. And there's so much learning on those calls. I'll also say, from a collaboration and coordination perspective, data on what's happening is really important. So we are building a community information exchange, which allows for closed loop referral, data sharing across agencies so that agency number A knows that person Crystal needs services from agency number B or letter B. So really making sure that data are able to be shared across agency, that really supports collaboration. And then the third thing I'll add is financial resources. Some people do this work because it's part of their everyday salary. Other people are able to do this work because they're able to be reimbursed. Make sure that people's time is covered at a rate that is livable.
Mhm. Yeah.
I will just add that, unfortunately, maternal health care in the United States has become very fragmented. Prenatal care, not so much, but postpartum care, because of the postpartum care cliff, where payment and services end from the obstetric provider at 6 weeks, which is now going away, by the way. But because we've had to work quickly to try to close those gaps, and there are startups and others, I think coordination has become challenging, but is very much necessary among community-based organizations and treating providers. I will also add that we find midwifery-led care seems to be able to coordinate and knows how to do this really well. So I point to midwives as a model that should be replicated and supportive, and is very supportive of coordinated care.
Yeah. Yeah. And I was actually going to say something very similar, which is just that far too often we are working in silos, right? I will have my data, Veranda will have her data, Crystal will have her data. The more that we can do to break that down, right, and really present a unified front and say, irrespective of the specifics of exactly how we're doing it, this works, right? And we need to be coordinated in how we think about regulatory evolution. We need to be coordinated in how we think about reimbursement, because the more folks we can get participating within this workforce, the more mothers will be helped, right? And that helps individuals, families, communities. It also helps taxpayers. And so we need to come together and structure this in the right way for the future.
Thank you all. I'm starting to see the numbers drop a little bit, but Griffin, if we go back one slide really quick, I do just want to address some of our federal policy opportunities. So why did we talk about this for an hour today, right? Because there are a lot of things that we can do to improve in this area. Very quickly, community health workers came up a lot. I am sure you heard overwhelmingly that the funding of community health workers is not working. The reimbursement is not quite working. So one of the ways that federal policy can help is to establish sustainable Medicaid reimbursement by creating those standardized billing pathways and integrating community health workers into value-based maternal care models. Another thing we had discussed, I know Joy also mentioned the HEDIS metric. So currently, the HEDIS metric, looking at postpartum care, stops tracking at 84 days, which is 12 weeks. As we know, there's a lot that can happen to a woman after she's given birth, well past 12 weeks, especially in the mental health space. So we actually have language that is currently in the fiscal year 27 House Labor Health and Human Services report that would increase that metric from 84 days to 1 year postpartum to allow us to collect more data during that time. Additionally, the Momnibus representative or Congresswoman Underwood also talked about her Momnibus. We, of course, support passing that comprehensive approach to improve the outcomes, reduce racial disparities, and then ensure that mothers have the high quality care that they deserve. And last but not least, funding for community-based care. Funding for this type of programming needs to be increased to meet people where they are to improve their outcomes, specifically for those in underserved communities. And additional funding should be going directly to organizations so that they can expand their services. Sometimes there's some barriers to organizations getting funding for a variety of reasons. I'm sure we could do a whole nother webinar on why things like that happen. But we need to do everything we can to get funding into the hands of those that are doing the work at the community level. Because as you can see, they are definitely changing lives, saving lives, and making a huge difference. I want to thank all of our panelists, everyone that joined. There was so much conversation happening in the chat. I hope you all were able to read that and connect with one another. Thank you so much. Thank you for your support. We will send the slides and we will send the recording.